First of all, I like to know my audience, our audience. How many are you nurses? Hold on, let me check. How many are school nurses and how many nurse practitioners? Any physicians? How many of you, I don't want to be personal, but how many of you have someone in the family, including yourself, who has endometriosis, mother, sisters? Very, wow, this is a great crowd. So I'm a surgeon, I work at this hospital. What did I do? Okay, yeah. Right. So I work approximately 100 feet away from here, room 24. Every Friday I start at 7:30. My wife here, I thank him for everything. She knows what time I go home. I mean, sometimes 2 weeks ago I was home at 3 o'clock in the morning. We do get very, very difficult endo cases, which you will be seeing. I really thank the foundation that gave me the power to speak here today and have the passion to continue to talk and do our cases. We all thank our patients for their support. I'd like to thank you for this Saturday you all came here. I'd like to really thank the foundation's dear supporters, Jan, Alexis, Christina, that helped this organization, that this meeting happened. Of course, I'd like to thank Lenox Hill that giving me a room dedicated for endometriosis surgery. I think it's unique. We have a team of surgeons, we have a team of nurses, techs that knows what goes on in this room. Okay. So the first slide is about a lecture I'm part of next week in Las Vegas. I'm one of the teams that are going to be talking about deep endometriosis surgery. I will talk about complications in this course, but look how this course is described. Due to the inexperience in appreciating diagnosis prior to surgery, the complexity of surgery itself, and the potential need for a multidisciplinary approach, many women with deep endometriosis are not satisfactorily treated at the time of their initial laparoscopic surgery. Would you all agree with that? Yes. It is true as it was years ago. Nothing has really changed. Today's subject, especially my subject, surgery, with respect to children, adolescents, and young adults, it gets more complicated. So, sorry, but this is a surgical video. I don't have many surgical videos, but this is just to give you, I hope you can handle it. This is a nurse that for infertility purposes that came for 10 years, she was on BC. Her pains have started from childhood. Deep endometriosis, she couldn't walk, she was always holding her left leg, and this is what we saw. The nature of the disease, I want to say, it looks not bad for many gynecologists, but as you touch it, as you move in, it's deeper, it is way beyond deeper than it is, like an iceberg. So in this case, I want to, we do these kind of cases. You see the left ovary on the side, this is the left side broad ligament, and the leg is on. We basically free the ovary, then we pull the ovary up like an ear is hung, so it frees, and we go to the adnexa. We really clean all the tissue as we can. This is a suspension technique we use. After the ovary is cleaned, I put water and I give blue dye beyond the peritoneum, so it gives me a great contrast. All the lesion pops out, so I know where I will excise. It's not what I see with my naked eye, it also gives me a great contrast. Then we go retroperitoneally and we cut everything above the ureter and free it. This is all diseased tissue. There's disease there. And it's a very critical, very dangerous area that we need to clean. Otherwise, if you leave tissue behind, the patient comes back. She's never treated. Even a little bit is enough to, we really don't know what lesion really causes symptoms, right? So let's move. I just want to show you. You look at this picture right now, many doctors here in my hospital even, little scar tissue, no problem. They would say this. However, when you give the dye, look how this peritoneal is deformed, like honeycomb or a leopard skin scene. More lesion pops out. This really tells me how wide I should go, how deep I should go. All right, the ureters are the things that we really pay attention, and the rectum. So endometriosis is like, it's like a rock and hard place. You really cannot, you get stuck, especially after so many years of suffering. The woman comes at the age of 30 to 40. It's in the period they've been suffering for 20 years. Everything is hard. There's not, you do excessive surgery, you end up with complication. You do little, it's never enough. You don't know what to remove, what to leave. Everybody wants to leave their fertility, their uteruses. They want to protect the ovaries. So it's so difficult on us too. For years, I found myself in the dilemma how to do better and better. And I think that's why we're here today. We're here for today for those kids who would end up, if we don't do anything, would end up like a final end-stage endometriosis. Can we prevent these diseases? Can we do something early so these women can have kids, do not go through hysterectomy or unnecessary 500 surgeries? So this is a picture I took to Iceland, 2006. So we have a fellowship program in this hospital. This was supposed to be my first slide. And obviously, politics is never when it's female issues. Melissa Harris, I couldn't believe when I see her pin, it writes uterus there. Look at that. I knew something was cooking. And there you go. And Elizabeth Ann Levy comes and talks about her endometriosis in the political scene. Everybody's heard about her story. So this is highly politically charged, but we haven't done much. I mean, we talk. Talk doesn't get anywhere. This is somebody whose writing I adored, and I recently know this person just by reading her stuff. She's a social anthropologist, only studies endometriosis. I couldn't help it. Her writing is so beautiful. Let me introduce you. Her name is Emma Whelan from Nova Scotia, Canada. She's a social anthropologist, PhD, has written beautiful articles on this. And I called her, Emma, I read your stuff. I cannot help you not to invite you to this meeting, but she couldn't come. But I will introduce you to the crowd. I said, look how beautiful she wrote her story. I said, write me your story. Let me hear what's the situation with you. So she wrote me this, so I thought I should have to ask her permission, but I did not. She'll forgive me. But as you see that she remembers her mother's problem. As I remember, the surgeon who, upon his first visit with his mother, scheduled for his emergency hysterectomy, the surgeon who said that, when he opened her up, she was such a mess of adhesions inside that he could hardly tell one pelvic organ from another. Under my mother's tutelage, I learned not to be the nervous type, especially not when I met with doctors. And I learned to suggest endometriosis and push for diagnosis when I had chronic pelvic pain in my early 20s. My doctor listened, and my life has been very different from my mother's. What strikes me as a sociologist who now studies endometriosis is that incredibly 30 years after my mother's hysterectomy, so many people still tell stories like my mother's. I will leave like that. I mean, I will just tell you very briefly how I look at this. Endometriosis is a syndrome of pelvic pain in reproductive age women, primarily with periods, gastrointestinal symptoms, fertility, and loss of quality of life. And it's all about period. It's the disease of the periods. It's the disease of menstruation. It's that like menstruation gone wrong, uterus gone wrong. So many things happen. Every month there's ovulation. Then 15 days later there's period. If there's no pregnancy, 400 of them in a lifetime of a woman, this does happen. But there are periods that do not come out. Endometriosis is the disease that those periods that never made out, stuck inside. So inherently, these endometrium itself, genetically, its material, is different than the people who don't have it. Those people who have endometriosis, their endometrium, their cellular components are different. They stick differently. The body cannot clean that period material fast enough. And it really comes from this endomyometrial junction, we say, where there is the production of every month menstrual material, stem cells. The body's richest stem cell factory is endometrium, getting ready for a baby. All those cells are ready to differentiate so fast, so adaptable, so that those cells go probably through some mutation. And when they come inside the peritoneum, probably body is fooled with those cells' ability to adhere, because the cells go there, actually die. Normally they die. They're eaten by the body's defense system, right, in the peritoneal fluid. But then some cells fool the body, and they give fake pass in a way, and they are admitted and they cling and become as endometriosis. It's the endometrial tissue outside the uterus, but really not exactly the same tissue. So the reproductive tract has a lot of things to do, so I did mention about endometrium. We're going to go into that. But basically, even the nerves in endometrium is different in endometriosis patients. These endometrium have different nerve cells. That's why they transform into nerve cells. These are all proven. And there are obviously women with obstructive outflow difficulties and fibroids, adenoma. We believe right now even fibroids are from stem cells gone wrong. The story is going there. Sideways is similar. Fibroid are the progesterone-dependent unwanted son, and the endometriosis is the estrogen-dependent unwanted daughter of the uterus. Right? So in the end, they destroy the uterus. One thing about pregnancy, endometriosis patients have increased implantation difficulties, early pregnancy loss. Later in pregnancy, they have 10 times as much complication as placenta accreta, percreta, and bleeding issues in the third trimester. We just had 2 hysterectomies in the last couple months here because of this reason. This is a slide of an outflow of difficulties. Thank you, Dr. Rigard. She made sure that I put this slide. Unilateral, persistent, painful cramps during the first year of menstrual life may be an indicator of outflow obstruction. That's Dr. Rigard's words. I stole it from her written material. Is that right? Did you mention this? So there are ways of different type of malformations, obviously. You can have double uterus, septum. What we are saying here is rudimentary horn. Not that common, but there's no need to really, you got to be sharp here. If there's one side pelvic pain consistently, there is something different going on there. And that could be a rudimentary horn. The period is accumulating there, never coming out. It needs to be diagnosed. So those people should not be on birth control pills and everything immediately. With an MRI, they could be diagnosed. So what is the origin of endometriosis? As I told you, it's the stem cells. Stem cell is the recent theory. It really embraces all the other theories of the old times and brings a new vision to it, new lenses. Now it really is the code. I think we're deciphering what's happening there. By the way, did you notice I also raised my hand, if anybody. My family has a very strong male breast cancer and female ovarian cancer. And I operated my own cousin for endometriosis, and it came back cancer. And he's young, 41 years old. So I am very interested on the subject personally. So we will go on this. So basically, these cells have a way of attaching. And peritoneum is one of the most beautiful, it's an organ, one of the most beautiful organs in the body. It's very shiny, transparent, one cell layer underneath, beautiful fibrous material. But what happens when this menstrual blood comes, it starts hitting the first cells, and they start detaching from each other. You will see this is iron deposit, hemostatic macrophages. These cells lose its connections. So next layer of cells that come, as you see, the underlying vessel is spiraling from that effect. I whenever I look inside, as soon before even I see the pelvis, when we start laparoscopy, if on the bowels, if we see these spiraling things on the bowel, I definitely know there's endometriosis, because this is a specific, sign how the vessels are reacting to this possible endometriosis initiation in the pelvis. But it happens in this appendix, actually. It doesn't look like typical endometriosis, but how these vessels are curved and engorged. It's almost similar to the spiralization of the period under estrogen effect as day 14. So this is an animation I created, and what you see is continuous overflowing of blood, how it accumulates as a debris, as a layer up there. These eventually will separate these cells, and the iron contents will sink in, and the vessels will pop out, and these stem cells from above, who doesn't want to die, who give SOS, and the stem cells from below has a way of communicating. The guy downstairs, the vessel one, will save the glands upstairs. It will reach with a hook of new blood vessels, and when they're crying for oxygen, those cells will eventually be made part of the body, will be admitted to the house. And then it's graft versus host situation. You know that phenomenon, right? You take someone in, and he takes care of you in the house. So basically, exactly that's what happens. These vessels go up, and there's SOS communication between these. This is my way of understanding how this is. I've been showing this. I'm getting good response on this. So basically, in the end, as this communication, these vessels go up, they know something is happening here. They know another gland will come. You see how that spike there? I'm going to show you these pictures. This is exactly happening. I'm a photographer. I love to take photographs. You're going to see beautiful pictures. So once this glands come, as it dies, now this guy is ready to save and give a rope to the other guy up there. And look, the color is brown. You're going to see that. This should be a little bit fast forwarded. I'm sorry about it. So this is just, yeah, it takes slower. So E.T. Bang. So the gland is finally oxygenated. So it's part of the body. It's over. Now it will survive there. We call that inclusion cyst. Every month, it will be renewed. The new stem cells will replicate it, and new ones will be. This is the example of how the peritoneum is destructed. The vessels pop out. You see this neovascularization and microperiods. And micro bleeding, right? And something happens from the vessels that comes from one side. I thought I should show you these because I don't think you all read textbooks and stuff. I don't think you have a chance to see any of these pictures at all. Nobody really sees, because I am also very interested in these. That's why I take a lot of pictures. So these are fibral changes in this. So again, bleeding. Oops, I'm going. So different, and it gets deeper and deeper. It gets white, fibrotic. Now it's attacking the nerves underneath. Now it's the tip of iceberg. You don't know what's behind this. If you lift this up, you can have big lesions. You don't know what's there. It can obstruct the ureter. It's on the rectum. Yeah. So there are nerves on the side that are ureter. So every time these blood vessels are formed, there are nerves around them, right? So endometriosis is really inflammation that goes all the way into neuropathy. Nerves are directly or indirectly affected. Very fast on staging. This is my staging of endometriosis. You've been reading about this staging, AFS staging. It has nothing to do with patient's pain. It doesn't. How can you stage patient's pain? Pain is very personal. And it doesn't correlate. You may have a small lesion that's causing, and you don't know how deep it is. It may look normal. You don't see how deep it is. So we cannot stage the endometriosis the way fertilitists are doing it. Fertility people are doing for their own reasons, not for pain purposes. I have said, and a lot of women talk about it, there's stage 5 endometriosis, when the disease invades the whole uterus, vagina, bowel, into the mucosa of the bowel, into the ureter, into diaphragm. This disease is different than simple stage 1 disease when you have implants. And there is deeply infiltrating endo, doesn't need necessarily is organ infiltrating disease, which is stage 4. Very fast we're going to see these. This is an animation how rectum is pulled up. And this is vagina, normal, healthy, sexual act. I depicted that. I mean, how the cul-de-sac is an incredible place where the baby really comes out. It gets as big as 10 centimeters, and it folds. We remove a lot of specimen from the right-hand side, from that's a very thin area. That's the natural orifice surgery, right? You've been hearing. That's how things really come out. But you see what happens there when the endometriosis invades, that dyspareunia. In other words, another look at this area, how the adhesion starts from the sides and starts obliterating this. As I was telling you, it's a retroperitoneal disease. It goes, this is the cervix, ureter. It goes all the way, causes hydroureter, all the way to the obturator artery. We've seen cases like this. These people cannot walk. So in the end, obviously, this little animation shows you how endometrioma is formed. This is, again, inclusion cyst. And these chocolate cysts at one time breaks. The patient ends up in an emergency room. Endometriomas typically start later. They're asymptomatic. They don't really cause as much symptom as peritoneal endometriosis. So overall, over the years, as this spill out to the pelvic cavity, the rectum fuses the back of the uterus like this. So I'm just showing animation, no blood to you. So this is another mild disease example. This is a small endometrioma on one side. And this is how we see the peritoneum gets these little pockets, fibrotic on the left. And it breaks like this, you know. We've seen, I'm sure Dr. Rigard have seen many of these cases, ruptured endometriomas being admitted as PIDs and nobody believes there are no temperature, no microorganism is developed. They're getting triple antibiotics. Poor girl I didn't sleep with anybody for 5 years or whatever, never had, but hey, it should be PID. We all know those cases. So this is a cyst capsule that is like big butterfly. We need to take the cyst capsule right this. This is a case I just did, basically infected endometrioma with suture material that they couldn't, supposedly she had both ovaries removed, but her ureter is obstructed on the left side. And obviously the disease goes to bladder. We clean the bladder. This is bladder. Endometrium is out, you know, on repair. It's on the ureter, the hysterectomy material. So you put sometimes stents from reversely. It's in the rectum. And sigmoid. So when we come to the kids, though, kids have different view of endometriosis and laparoscopy. The red lesions and the vesicular lesions are the most common. It is different than adults. And adolescents with cyclic pain, nausea, and constipation and have the largest proportion of red lesions. This has been known for a long time. But when the redness turns into white scarring, we see persistence of pain and more prevalence of these patients. Larry Demko, friend of ours from Canada, has done these kind of work a lot. So they have really looked at the areas where endometriosis is found in adolescent patients, and I am not sure how much I agree with everything because everybody has different way of describing these things. I find in my population, but in adults though, I find endometriosis more in the non-reproductive organ surfaces than the reproductive organ surfaces. In other words, more on the pelvic side walls, more on as much in the rectum or deep pelvis than the ovary and tube. Rarely it's on the tube, actually. Despite everything, rarely it's on the tube. And in the ovary, really, it is not as common. When it is, the endometrium is the worst thing that's really, when there's an endometrium, there's like an internal endometrial cavity. It's like she have secondary cavities, has internal periods. But if there's no endometrium, things are different. So in our series that we did almost 1,500 excision, only 20% were in bowel and the rest were lateral walls. Lateral walls is more than cul-de-sac actually, both lateral walls. So the endometrioma is something that we need to be very careful. There are 3 types of endometriosis. One is peritoneal, one is endometrioma, and the deeply infiltrating endometriosis of the cul-de-sac. But when there's endometrioma, there's always peritoneal endometriosis. But most of these patients, up to a certain point, can be asymptomatic. And once they break, then after that, some people will see in the symptomatology section, I'll show 1/3 of the patient never complains about pain until the age of 23, for example. So chocolate cyst in the end, we've seen this one, actually. Let's move on. How am I doing with my time? Okay, cyclic pain is the most common component in these girls. 80% of the pain have primary symptoms, to some 90, to some 70, but most common is painful period. In the absence of period, cyclic pain is it varies from 9. I see more gastrointestinal symptoms in these patients, and obviously we should be aware of these. So what is the treatment? Unfortunately, the only treatment that works for these right now, practical, is surgery. Good surgery, quality surgery, very meticulous, very pixel resolution style surgery that doesn't leave the disease behind. So today, I think you need to be aware, doing laparoscopy doesn't mean that someone is doing laparoscopic surgery for endometriosis. Doing laparoscopic surgery doesn't mean that they are removing the disease. Doing minimally invasive surgery has nothing to do with endometriosis surgery. Endometriosis surgery is the most difficult surgery you can ever imagine. It's much harder than cancer surgery. Oncologists, GYN oncologists, when they see endometriosis, they scratch their head, they change their direction. It is true. And they just say, it's not cancer, I don't want to deal with it. Because they all work for an institution. They all come from an institution. They're not trained. They don't listen. They are semi-God. I am very open about it. I just say to their face also. So, unfortunately, a lot of patients do come from their hands too. Unfortunately, not treated completely cleaned up other than hysterectomy. Hysterectomy does not clean endometriosis. If you don't clean the disease that's outside the uterus, right? So laser surgery is not, robotic surgery, it doesn't. It's the excision surgery. Ablation, this is fulguration. This is the electricity being applied. You see how that surface tension increases, how that peritoneum gets tight. Many of my patients who come to me are treated with fulguration. We do 4th surgery. One person I've operated 4 times, 5th time. So, this is the excision model we have, that you clean up and the surface tension gives up everything. You can see the underlying tissue if there's anything left. If you don't really give power, electrical power, the tissue is its original color. You can see whether it is blood, this and that. So we use microbipolar to control mini bleedings and everything. So, oops, what's this? Oh, this is with laser again. Laser, there's no biopsy. It uniformly, beautifully ablates, but there's no pathology. Again, the tissue is cooked. You don't see the underlying tissue. You may leave, and there's a high rate of complication in the inexperienced hands. So this is another model, just plasma jet ablation, which I don't use. I only use excision. So with excision, the tissues let go, organs return to its normal, retract back to their. We think like that. That's how the pain is diminished in these patients also. So let me just go fast here. Almost done. This is a case we did with neurolysis, the psoas, all the nerves. It's a young woman. This is her 4th surgery, operated by same doctor, very conscientious. When I looked at her OR report and pictures, luckily I saw how she did. She has used electrical power on the bowel on the left side. As you see, the ovary is suspended. This is ureter. You're seeing this way, pelvic sidewall. On the left side, you see the nerves there, which I almost by accident, if I wasn't I probably have slept that well that night. I could have cut very easily. So this is how it started. And this is the nerve. How is it attached? This is endo. It came back definite endo. This is the lateral cutaneous nerve on top of the psoas and iliacus muscle on the side. As I move on, more nerves are coming. This is the, I think that was the ilioinguinal. This is the lateral cutaneous. This is the medial one. And this one comes out. This patient, the next day, she thought her leg was freed. She's 20-something, very young. So this is the nerve, yeah. But this was her 4th surgery, I think, 4th or 5th. All right. So this is how the nerves looked. Almost done. This is an excision specimen. Let's move. I use basically scissors. So just briefly, ending my presentation here. Surgery is based on the principles of removing the glands and fibrosis. It's the same thing like oncologists do cytoreductive surgery for ovarian cancer. This is the glandular fibrotic reduction with the purpose of restoring and restoring the normal anatomy. And complete surgical removal does not relieve symptoms for at least a year in 50% of the patients. There will be patients coming back after surgery. There is no prospective study, unfortunately, in kids. One study was done retrospectively by Stropolis and Sardoan and from London. And one is from our friend, Dr. Patrick Young from Atlanta. They did 20 cases, only 20 cases. They removed excised though. In 17 of the patients had endometriosis confirmed, and they followed for 2 years. And statistically, pain symptoms, bowel symptoms, everything improved. However, 50%, 47%, they had to redo the surgery. But when they redid the surgery in excision patients, pathology was negative. There wasn't much endometriosis inside. And this was a very good study. So I think one hope I can tell you today, which I use, now we have, which I've been using microlaparoscopy for many, many years, but technology wasn't there. We used to have rod lenses. I even did a hysterectomy in 1995 with an Imagine. The company's name is Imagine microlaparoscopy rod. We did suprapubic hysterectomy, probably the first one in the world in Brooklyn, where I was practicing at that time. So now we have 3 millimeter instruments like this. We can really go inside and see at this resolution. This is a patient that is from childhood she's having. She's a patient who is known to Dr. Wilson also. We can go inside and see with the resolution, at least can diagnose without what you can plan what you have to do with the patient. It's 3 millimeter. When you take out, there's no incision you have to close. Very aesthetical. Nobody knows she has even had surgery. And it could be done even under local anesthesia. Right? So this is, on the left side, it's the regular 1 centimeter scope, 3 millimeter scope on the right-hand side. This is my OR. I took these pictures with my new iPhone yesterday. As I said, it sucks, you know. It's not that good. I did panoramic picture. It worked in one side. Then if you do close-up, everything looks like this. So this is, on the right side is a normal instrumentation. This is microlaparoscopy on the right-hand side. This is the lesions you can see. I mean, you can see the lesions. Then you can move ahead, and you can even do the same surgery with it. You can stitch with it. No problem. So key point, endometriosis is confirmed. 50 to 70% of adolescents who have pelvic pain fail to respond to oral medication. So let's remember that, all right? Evidence shows that cognitive behavioral therapy can improve a patient's response to directed. So Surgery, yes, fine. Medicine, fine. But support. The patient, the kid needs to understand what she has, and she needs to be loved and cared for. She needs to educate herself, and we need to be honest with how she interacts. Dr. Wilson will talk about the subject, and it's a great value in the patient care. I believe that. Red lesions are predominantly in adolescents and are highly associated with pain, yes. Unilateral persistent painful prime during first year of menstrual life may be an indicator for congenital anomaly. Dr. Rigard, thank you. Mini-laparoscopic approach should be considered for diagnostic and cooperative person in treatment of adolescent endometriosis. And early diagnosis and timely intervention by excision surgery, complete removal may be the best prevention of the disease to prevent further problems. So, unfortunately, this is radical intervention, increased risk of major complications. Endometriosis surgery is at least 5 to 7 times more morbidity-wise complicated than normal surgery, and complications are as much, at least 7 times as much. There are more complications with endometriosis. Well, I hope for better days. The waves gives us hope, the beautiful days for these kids. I hope we can help them. I really appreciate your coming here in this beautiful day. It was supposed to be raining, but I hope it will mean something for the future. Thank you very much.
Thank you, Dr. Seckin. At this time, we're going to open the floor for just only 2 brief questions. We have addressed the room temperature in the room, just so everyone knows. So just give it a few minutes, it'll warm up. So questions, we can take 2, and then we're going to take a break. Yes?
Doctor, does diadelphys uterus and endometriosis has any connections?
I'm sorry, say it again?
The diadelphys uterus and the endometriosis has
diadelphic uterus
and endometriosis has any connections?
Of course, there's a higher rate of endometriosis and congenital when there is any malformation in the outflow. It is, we do expect more incidence of endometriosis. But that doesn't mean that it's interesting. I've seen many cases of these, the surgery on this. They don't have necessarily severe disease, though. They may have mild to moderate endometriosis. They don't necessarily have deeply infiltrating endometriosis of other organs and stuff. So that is a different animal, that extensive endometriosis. It's the stromal component that's aggressive. It's a separate ball game. Yes. Yes.
Okay. Harry, excuse me.
Thank you very much for your excellent presentation, Doctor. I do nursing research for a major law firm, and I was told that mononucleosis contributes to endometriosis because it reduces your immune system. Is that?
I will defer that question to Dr. Rigard. I don't have any idea, nor I have ever heard.
I have not seen that in the literature. In preparing for this talk, I pulled everything from medical therapies. I have not seen that in the literature, but I think we do know that endometriosis runs higher if you have lupus, rheumatoid arthritis. Any women who suffer from immune diseases are more likely to suffer from endometriosis. I haven't necessarily done a literature search for mono directly.
Thank you, everyone. We are going to take a 10-minute break. All right, thank you.